Good afternoon, everyone, and welcome to our Healthcare Homes webinar series presentation on building trust in culturally diverse environments. My name is Katherine Johnson, and I'm the Learning Manager for the Healthcare Homes program. Thank you all for joining us today. We are excited to have you back on our webinar series after our hiatus for Learning Days 2025. We hope many of you were able to join us there and found it valuable. For those planning ahead, we are already working on next year's Learning Days, and we hope to see everyone there. Before we begin today's presentation, I'd like to share an important acknowledgement from the Minnesota Department of Health regarding the land that we're on and our commitment to Indigenous communities. Every community owes its existence and vitality to generations from around the world who contributed their hopes, dreams, and energy to making the history that led to this moment. In Minnesota, we are standing on the ancestral lands of the Dakota people. We want to acknowledge the history of this land, including the Dakota, the Ojibwe, the Ho-Chunk, and the other nations of people who also called this place home. Native peoples were removed unjustly, and we in this space are the beneficiaries of that removal. At MDH, as we understand that land is related to health, we want to be good stewards of the land we are on. This acknowledgement is just one piece of that. We understand that systemic racism, historic trauma, and genocide that has impacted the Indigenous communities and the peoples in our state. We recognize that a land acknowledgement is a first step. We support this action with resources and shared decision-making to meet tribal public health priorities and needs. With our Indigenous neighbors and coworkers, we can advance health equity and work to ensure all communities across the state are thriving and all people have what they need to be healthy. We encourage state employees and the public to research the history of the lands that we are on, and if you are able, find Native-led events to attend, organizations to support, and causes to champion. Before we get started, I have a few quick housekeeping items. Please note that your microphones are muted upon entry. Please put your questions into the chat and we will address them during our Q&A portion of the presentation. Also, this webinar is being recorded. Today, we are honored to have three exceptional speakers joining us, all from the Minnesota Department of Health. These professionals bring decades of combined experience in healthcare interpretation, community outreach, and health equity work. Their diverse backgrounds and specialized expertise represent the collaborative approach needed to address health disparities and ensure effective communication across cultural and linguistic barriers. Let me introduce each one of them. Our first speaker is Lisi Tao. Lisi brings over a decade of experience as a certified medical interpreter through the Certified Commission for Healthcare Interpreters, CCHI. Her experience extends beyond interpretation. From 2004 to 2006, she served as a U.S. refugee resettlement caseworker based in Thailand, working directly with Hmong, Lao, and Karen Burmese populations. Next, we are pleased to welcome Yanina Rodell. Yanina is a member of the American Translators Association and holds specialized credentials as an ESL specialist from UNMSM and Spanish for speakers of other languages specialist from PUCP. With over 25 years of professional interpreting experience in both education and healthcare settings, she has dedicated her career to serving as a bridge between the Spanish-speaking communities and essential services. Finally, we have Dan Tam Phan Nguyen. Sorry, Dan Tam. Dan Tam has spent more than 10 years working to alleviate health disparities through the advancement of health equity and social justice across multiple sectors. She has played a key role in the Minnesota COVID response and has been featured as a state culture communications initiative, which highlights innovative approaches in reaching diverse communities during public health emergencies. Now I'd like to turn it over to Lisi. The floor is yours.
Thanks so much, Catherine. My name is Lisi Tao, pronounced she, her, hers. I will be opening the presentation today about building trust in culturally diverse clinic environments. All right, we could proceed to the next slide, please. And we will skip over this as Catherine has already read it through and go right next to the general overview of today's presentation. We will cover the topics of cultural beliefs and practices for Hmong, Somali, and Spanish-speaking communities, followed by causes of patient mistrust toward provider and medical institutions, and then strategies to building trust, and end it with a conclusion. Next slide, please. So first, I will start with the cultural beliefs and practices in the Hmong community. Next slide, please. And topics that I will cover for the Hmong culture will be demographics, beliefs and practices, ailments, and communication in Hmong culture. Next slide, please. The Hmong in the U.S. today arrived as a result of their alliance with U.S. forces during the Vietnam War, which heavily impacted neighboring countries such as Laos and Cambodia. Currently, Minnesota is the only second state to California as having the highest Hmong population in the U.S. And according to the Pew Research Center, over half of the current Hmong population in the U.S. are U.S. born. That does not mean, however, that language access is not a needed service for those who have limited English proficiency. Next slide, please. So regarding Hmong beliefs and practices, traditionally, Hmong people are very animistic. That means that they believe many things, including living and non-living things, have spirits. This includes homes, lakes, rivers, and forests. There are good spirits that bring prosperity and protection, and then there are bad spirits that cause sickness and ailments. When ailments that are believed to be caused by spirits happen, shamans are often called to diagnose and treat the ill person as would a medical doctor. There is a word in Hmong that is equivalent to trauma. It is called bong li, or literally fallen spirit. When a person experiences a traumatic event, such as an accident that causes emotional or physical harm, it is often believed that the person or the people involved may have likely had their spirits out. So the cure for this is usually for an elder to bring a live chicken and an egg to the area where the incident took place and perform what is called a soul calling ceremony. In addition to that, superstitions may also play a role in traditional Hmong beliefs. One of this example is ensuring that there are no metal components buried with the deceased loved one, as it is believed that this could show up as an illness or an ailment later on in the deceased individual's descendants. Moving on to mental health. Mental health is a very complex issue as it is not often talked about. And this is because due to a lack of understanding, the stigma attached to it, and simply downplaying the importance and impact that mental health has. And as a matter of fact, there is no translation for the phrase mental health in Hmong. Many mental health conditions also do not have translations. There are many older generations of Hmong who lived through the Vietnam War who have untreated wartime trauma. And again, this is due to a lack of understanding, lack of resources, and the stigma attached to it. So you can imagine that receiving therapy and psych meds, that is a really new concept to the community. Oftentimes, mental health is viewed as being tied to spiritual health. For example, if someone says that they're worried about something for a while, they're not feeling all together, or something's bothering them emotionally, a shaman may be consulted. Moving on to herbal medicine and folk wisdom medicine. Often this is trusted because it is passed down from generation to generation. And then sometimes it can be purely anecdotal, meaning that if it worked for someone else that they know, then they trust that it would work for them as well. Another example of using herbs for healing is in the postpartum diet that is given to a woman after she has had a new baby. Her diet will consist strictly of boiled chicken with herbs, and the herbs are believed to speed up healing. And part of this is what's called the month-long postpartum confinement. It's done for spiritual and practical reasons. So practical reasons being, of course, that she needs to heal, but she also needs to stay indoors to avoid outside elements such as the wind and cold. And then the spiritual reasons that she would have to stay inside for 30 days is that she cannot enter the home or homes of anyone who is not part of her husband's immediate clan, as her body is still healing and she is considered unclean. So if she were to accidentally enter a home as mentioned, she and her husband's family would have to call on a shaman to remedy the offense. So a lot of spiritual beliefs there. Next slide, please. There are many medical ailments that do not have names nor even proper translations in Hmong. These also include lack of names and translations for certain body parts, such as the nervous system, nerves, cells, glands, to name just a few. In my past career as a Hmong medical interpreter, finding proper translations for these terms was one of the more, if not most, challenging part of the job. And so an alternative to translations is often simply describing what the condition is, such as the examples, excuse me, listed in the second main bullet point here. For example, gout is called katavu, or literally crazy foot. Diabetes is called nchakaji, or sweet blood. High blood pressure is nchashia, or high blood. And then tuberculosis is gamonjuhua, or dry lung disease. And then sometimes we simply just use the English names. For example, cancer is cancer and stroke and allergy. We just use the English phrase since there's really no simple way to even describe it in Hmong. Next slide, please. Now we will talk about communication in Hmong culture. There are certain body languages such as prolonged direct eye contact and being too close to another person's personal space are all considered rude and inappropriate. And then for sensitive topics or for when there's a conflict of some sort, oftentimes indirect communication is the preferred mode. Say, for example, if someone offended another person, whether it was through words or actions, broaching the topic might first involve referencing to the importance of harmony and cohesion before bringing up the core of the matter itself. And then also, depending on the circumstances, sometimes mediators are used as well. Now, reflecting again to my past work as a medical interpreter in terms of communication, there was a case where there was a young Hmong teenage boy in urgent care for an acute injury, and his mother was there as well. And she kept saying to me and the provider that her son was having pain in his belly due to an incident from playing sports earlier in the day. And the conversation kept going in circles with no concrete conclusion. And finally, when I sensed that the patient and his mother had some reluctancy in naming exactly what the problem was, I asked the provider if I could make a suggestion. And I have to say, this is one of the few and rare circumstances that was necessary for me to step out of my role as an interpreter and become a cultural liaison of sorts. So I suggested that perhaps the young patient and his mom might prefer a male Hmong interpreter instead, as the injury might involve some sensitive area of his body that he may not be comfortable talking about. And so the conversation went from reluctant and confusing to the patient having a big smile of relief on his face, and his mom, of course, chuckled and verbalized understanding. And of course, a male interpreter was called to replace me. And this is just one example of how communication can be improved by simply providing the appropriate people or persons for the conversation. And then moving on, nodding. In Hmong culture, especially in conversation, you might often see a lot of nodding happening, but that does not always mean that there is agreement, nor does it even mean that there's mutual understanding. Because the culture is very hierarchical, showing respect is prioritized. Nodding sometimes, or maybe even oftentimes, is simply to signify respect. And then on top of that, sometimes very traditional Hmong folks will simply agree because they are afraid to say no, especially when it is coming from what is viewed as a place or a person of authority, such as a doctor, a nurse, or a medical provider of any kind. So clarity is a must, meaning that the patient should be clearly informed about their options and rights when faced with a question or a situation that requires their permission. Moving on to handshaking. Although this is not a traditional practice in the culture, it is currently very widely practiced, especially among men. It is something that was actually adopted from Western culture, namely during the French Indochina era, when France colonized Laos, Vietnam, and Cambodia. It was passed down through that time. And then, as I said, mostly men practice this, but there are some contemporary women who will do this as well. And then physical touch, as mentioned earlier, a personal space should be respected in general, but even more so when it is between opposite genders. And then finally, the Hmong Romanized Popular Alphabet, or otherwise known as RPA writing system, was developed by American Christian missionaries and Hmong students in Laos in 1953. It rapidly became popular due to the ease of use and the fact that there were no other writing systems existing at that time for the language. So this concludes my segment on Hmong culture. I will now hand it over to my colleague, Dan Tam Van Huang, for the next topic. Thank you so much.
Thank you, Lacey. Again, my name is Dantian Phan Huang. I use she, her pronouns, and I am presenting about Somali culture on behalf of our team member, Mohammed Bolhan. Next slide, please. So this is the overview of what I will cover today. We'll start off with some norms found in the community, move into more sensitive areas and topics that you will need to keep in mind, and then ending with some common illnesses along with ways to treat them. Next slide, please. So the most important thing about Somali culture is that it is rooted in Islamic tradition. And what I mean by that is that Somalis tend to be more religious than other Muslim African populations. For example, the idea of a non-practicing Muslim is very unusual because everyone is expected to practice the religion to some degree. Another important aspect of the Somali culture is that it is communal and multi-generational. So there is a lot of reliance on other people. And in addition, there are extended family members living underneath the same household. It is also under patriarchy. So the eldest male in the family will be in charge of making the important decisions. Furthermore, regarding Somali spelling of names, there are inconsistencies. For example, in English, we have a first name and last name, or vice versa. There is no standard for the Somali names. So just keep that in mind as you see that there may be differing spellings of first names or last names, or the order has been switched on different documentation. And then wanted to also touch on that traditional healers are a big part of Somali culture. Two common methods that are used to treat common illnesses is bone setting, which is when traditional healers use wood and plants to heal everything from simple to complex fractures. And then cauterization as well, because Somalis believe that disease and fire cannot stay together in the same place. So burning can be used to treat hepatitis and facial paralysis. Next slide, please. So some of the more sensitive issues in the Somali community include mental health problems. This prevents people from accepting their illness and seeking treatment, and they often suppress their feelings. Oftentimes, it is due to the civil war. Furthermore, just going back to the idea that the Somali culture is very religious, having children outside of marriage is taboo, and it is outside of accepted norms. Other sensitive topics include rape and cancer, and people generally just avoid talking about these things. And this is because Somali culture is honor-based. So thinking back to that patriarchy, how the eldest male is in charge of the decision-making. If they are unable to protect a family member, then it shows that they have not done their job. Regarding cancer, there are a lot of misconceptions. And one of those misconceptions is that it is a very bad disease that will kill you quickly, where you lose your arms. So as providers, it is important to know that these are extra sensitive topics and keep this in mind as you discuss treatment with patients. Next slide, please. So back to how people suppress their emotions because mental health is taboo. Some of the common mental health conditions include substance use disorder. So to cope with the trauma from the Civil War, there is a leaf called khat in East Africa that people chew. It has narcotic properties and it's actually legal there. However, it is illegal in the US. Regarding trauma, as mentioned before, there is a civil war. So a lot of refugees and immigrants come over. And lack that community that is necessary for that support. There are actually clinical studies that show about 39% are affected by post-traumatic stress disorder in just the Twin Cities. And again, some of these causes are not being able to speak English, integrating into society, not being able to connect with community, the cultural differences, acclimating to the weather, and so on. Next slide, please. And if you have heard of anemia and female genital mutilation, also known as FGM, there are related complications that can commonly be found in the Somali community. So anemia mainly affects women and children. It's often due to malnutrition, eating habits, and lack of access to healthcare. While FGM is actually a cultural practice that circumcises girls, and this is to illustrate family and community honor. Chronic conditions such as diabetes and high blood pressure can be found among the Somali elders as well. Next slide, please. So I've talked a lot about illnesses and ailments and just things to keep in mind. Ways to treat them are massaging. And this idea of massage is when hands are used to push on the body until the muscle pain is removed. It's very different than the idea of the Western going to the spa to relax. Cupping is the belief that there is toxic blood that needs to be drawn out using a needle and suctioning through a cup. And then just going back to the idea of Somali culture is based on the Islamic tradition. Prayer can be used to treat the evil eye, which is a spiritual belief that is based on jealousy or revenge. It's also used to treat possession beliefs by reading the Quran, which is the holy book, and also through Islamic spiritual treatment. So since the Somali culture is very religious, some things to keep in mind is during the holy month of Ramadan, where Somalis are fasting, this may affect medication intake because sometimes medication directions include eating or drinking while taking medicine, and that's not something they will do during Ramadan. As well as just in Muslim communities, you are to abstain from pork products and alcohol, other ingredients that may be found in certain medications. So in order to provide culturally sensitive care, these are just some of the beliefs and different practices that you should be respecting as you pursue practices while offering Western medication and care. And with that, I will hand it over to my colleague Yanina Rodell to talk about the Spanish-speaking communities.
Thank you, Dantam. My name is Janina Rodell. I use she, her pronouns, and I will be talking about the cultural beliefs and practices in the Spanish-speaking communities. Next slide, please. The topics I'm going to be talking about. Is there a difference between Hispanic or Latinos? Getting to know the Spanish-speaking communities, common ailments, mental health conditions, barriers for Spanish-speaking communities, mental health, best practices to work with Spanish-speaking communities, creating a welcoming environment for Spanish-speaking communities, and 2 techniques when working with Spanish speakers. Next slide, please. Generally, when interacting with Spanish speakers, most people ask themselves, should I call them Latino? Should I call them Hispanic? Is there any difference between these terms? The answer is yes. And here is the difference. Hispanic refers to the language that a person speaks or that their ancestors spoke. Latino refers to geography, specifically people from Latin America, including North America, Central America, South America, and the Caribbean. So a person from Brazil is Latino, but not Hispanic. And a person from Equatorial Guinea is Hispanic, but not Latino. Next slide, please. Getting to know the Spanish-speaking communities. There is a diverse Hispanic or Latino community in Minnesota. While initially focused on Mexican immigrants, the Latino population grew in the 1980s with increased immigration from Central America. The pillars of the Spanish-speaking communities are family, religion, language. And why language? Because it is a powerful symbol of identity. The sense of belonging to a community and our values such as respect, kindness, trust, modesty, among others. Next slide, please. Regarding ailments in my community, Spanish speakers face illnesses such as obesity, diabetes, high blood pressure, neurocysticercosis, and TB. Next slide, please. Spanish-speaking communities in the United States and here in Minnesota experience high rates of mental health conditions like trauma before and after migration, PTSD, depression, stress, anxiety, and challenges of integration, especially minors who came to the United States and are here in Minnesota, who came without their parents or family members. Next slide, please. Barriers to Spanish-speaking communities and mental health. Stigma surrounding mental illness, language barriers, and limited access to care also present challenges in my community. Spanish speakers have to deal with gender role expectations and distorted ideas of strength. For example, traditionally, men are expected to be strong, assertive, and primary breadwinners, often leading to the suppression of emotions like sadness or vulnerability. And this can result in men struggling to seek help for mental health concerns or forming authentic connections. Women are traditionally expected to be nurturing, caring, and focus on domestic responsibilities, potentially leading to them neglecting their own emotional needs. Both men and women prefer to keep family businesses private. The reason for inadequate mental health education is that there is a prevalent stigma within Spanish speakers or Spanish-speaking communities, where mental health issues are often viewed as signs of personal weakness or lack of willpower. This can be exacerbated by cultural beliefs that emphasize privacy and self-reliance, leading individuals to internalize their struggles rather than to seek help. Lack of culturally competent care. The ability of healthcare providers to recognize and respect their patients' cultural differences and complexities is very, very important. The concept is critical considering this increasing ethnic and cultural diversity in population, even in the Hispanic community. What's the suggestion here? A cultural competent mental health professional will adapt their methods of diagnosis and treatments to the individual's cultural context, ensuring a more personalized and effective care plan. For example, what may appear as symptoms of a particular mental health disorder in one culture actually may be perfectly normal behavior in another culture. Understanding these cultural differences can aid mental health professionals in making more accurate diagnosis and providing effective treatment that respects the patient's cultural context. Religion as a replacement for mental health services. We all know that religion can be a positive complement to, but not a substitute for, professional mental health services in Minnesota. Faith communities can provide valuable support, reduce stigma, and connect individuals and resources, but professional treatment is necessary for diagnosis, counseling, and addressing serious mental health conditions. Next slide, please. So what is the formula? When we work with the Spanish-speaking communities, there is not a magic formula that works when we are working with the Spanish speakers. But there are some aspects to consider when working with them. For example, the support of the family and the community is important, especially when making decisions regarding their health. Immigration status. Many undocumented Latino immigrants experience difficult conditions before, during, and after migration. Increased immigration enforcement, changes in social networks, and discrimination impact their mental and physical health in a negative way. I hope someday, and I hope this can be true someday, what do Latino or Hispanic individuals need? They need access to affordable health and social services without fear of deportation or detention. Limited education and health literacy in the Latino or Hispanic community can hinder understanding of health services, preventative care, and prescribed treatments. This can lead to decreased engagement with healthcare and contribute to feelings of powerlessness. Finally, the process of acculturation may impact both social and psychological well-being. To improve interactions with Latino Hispanic individuals, we may be undergoing acculturation. Healthcare providers can focus on enhancing their cultural competence and cultural humility. These topics are going to be developed by Lizzie. Next slide, please. We all know that there are several factors that contribute to building trust in patients. These factors include effective communication, active listening, transparency, and demonstrating competence. If we already know these factors, my question is, why did we get these comments from Spanish-speaking patients? Why do they have to speak up? And the answer is because patients are more likely to trust healthcare providers who are open, honest, and actively involve them in decision-making processes. Showing empathy, compassion, and respect for patient feelings and experiences also plays a vital role. Next slide, please. There is a communication method used with Spanish-speaking communities that have good results. The learn technique and the teach back approach. Both of them, the learn technique comes from the acronym listen, explain, acknowledge, reiterate, and negotiate. Learn focuses, for example, on understanding the patient needs. And next slide, please. And teach back ensures that the information has been understood. The learn technique and the teach back approach is really good communication method used in healthcare to ensure clear understanding of information and instructions. It involves explaining information, then asking the patient to explain it back using their own words to confirm understanding. Next slide, please. I would like to conclude my presentation with a quote from Jason Wolf, president of the Verrill Institute. To truly improve the patient experience, we must understand the patient journey from the patient's perspective. So here, we need to take into account and emphasize the need to see healthcare through the eyes of the patient. This quote encourages healthcare providers to align their strategies with the patient's needs and expectations. Next, Liz is going to talk about methods and best ways to improve trust with non-English speakers.
Thanks so much, Yanina. So for the next segment, I will be talking about factors and causes of patient mistrust toward provider and medical institutions. We'll go right to the next slide, please. For a lot of immigrant and refugee populations, there are many factors that contribute to their mistrust toward medical institutions. Language and culture are the most obvious ones. But in addition to that, a lack of health literacy and difficulty in navigating a healthcare system can also be factors that lead to patients feeling lost, confused, and not understood. Even for many of us who don't face language barriers, we can still encounter difficulties navigating a complex healthcare system. So you can imagine that if you have limitations on top of language challenges, how much more complex it is to receive the care that you need. Beyond these factors, there are also historical trauma that some populations have faced, ranging from discrimination to socioeconomic disparities. Some may have had negative experiences in receiving care and have a fear of being used as test subjects. And then for some, they may not have health coverage or may only have minimal healthcare coverage, leading to a fear of, I may not be a priority if I do not have health insurance. And then in lieu of that, there's also the perception that the system is designed to be more focused on making a profit than caring for its patients. So in the next slide, please. I will be discussing about strategies to build trust and methods of how to effectively engage with patients from a different cultural background. Next slide, please. For a lot of individuals who have limited English proficiency, we must be mindful that not all of them can read and write in their native language. And even for those who can read in their language, some might still have limited literacy. Causes of this could range from socioeconomic reasons to a lack of educational opportunities, warfare trauma, and simply not having been raised in a culture or environment that supports reading. So because of this, verbal communication is often the preferred mode of communication. And with verbal communication comes the utilization of language interpreters, which I will talk a bit more about later in this segment. The other modes of communication are, as you see here, written, visual, and nonverbal. One key point that is worth noting is the patient's level of what's called technology literacy. For some patients, it is an added challenge on top of language challenges. We can't or shouldn't assume that all patients will know how to use technology and tools such as, say, for example, scanning a QR code or clicking on a link or filling out a form online. These can become another layer of obstacles to the patient in reaching their health goals. So it is always good to ask and provide assistance when possible in the utilization of these sorts of technology. Next slide, please. Here are some steps providers can take to build trust, ensure proper communication, and develop rapport with patients from a different background. We want to apply clear communication by using understandable language. Avoid jargon and explain medical terms in a way that patients can easily understand. And again, referencing to my past life as a medical interpreter, I can also vouch for this because despite the experience and training that interpreters receive, there may always be new medical terms that we're not familiar with. So using plain language is not only useful for the patient, but also highly practical for the interpreter as well. And then, of course, we want to ensure that there's language access, providing interpreters or using visual aids if needed. There's also a method called the ask, acknowledge, and ascend approach. When you sense that there might be some distrust or hesitancy, whether it's not adherence to treatment or rebuttal of medical advice, excuse me, one of the first steps is to ask the right questions in a respectful tone to try to understand the basis of their distrust. For example, you could say, is there a reason that you prefer not to follow this medical advice? Or have you had a bad experience in healthcare that made you feel this way? Next, we want to listen intently and acknowledge any concerns being expressed by the patient. By showing understanding, we can ascend the patient's distrust, establish rapport, and begin to address the problem. And then if there are any tests, treatments, or medications involved, we want to be transparent about those procedures and try to answer thoroughly any questions that the patient might have. Next, we want to apply active listening and empathy. By showing genuine interest in the patient's concerns and experiences, we can show them that we genuinely care and we genuinely want to find out what is going on, what kind of need that is needed for them. You want to validate the patient's feelings by acknowledging their emotions, even if it seems irrational. I recall there was a case back when I worked at a small family clinic. Elder Hmong man had latent TB, and he was very adamant in believing that the cause of this, we showed him the x-ray images, and he believed that the cause of that was from someone putting black magic on him. So what the provider did was he simply listened and he did not judge. He just allowed the patient to speak of his experience and his belief that this was some sort of black magic being put, some spell being put on him. Ultimately, we were able to give the patient the treatment that he needed. And so we did manage to get to the goal of his medical needs. So that's just one example of expressing empathy and understanding, even if it seems irrational. Empathy, of course, can help build rapport and create a sense of connection. Showing understanding and compassion can be a great bridge for that. Next slide, please. And then we also want to be mindful of cultural differences by acknowledging and respecting the patient's beliefs and practices related to healthcare. As mentioned in the previous slides, there are some communities that believe very strongly in herbal medicine, or they may have very strong spiritual beliefs. And then we want to show them understanding towards the impact of migration by recognizing that migration can cause stress, anxiety, and other health concerns. Oftentimes, refugee and immigrant patients have homesickness. So it is useful to remember that some of them left their homeland not by choice, but due to safety and security concerns. And then we want to show interest in the patient's lives by asking about their experiences and acknowledging their strengths and challenges. You want to offer a proactive reassurance by communicating clearly that their immigration status doesn't affect their right to receive medical care. We want to be respectful and non-judgmental by avoiding any assumptions or stereotypes about the patient's immigration status or cultural background. And then finally, if there are any rumors or misinformation, we want to try to dispel that. Sometimes there could be rumors circulating around a certain disease or condition. An example is, this is way back in my parents' generation, in their native homeland in Laos, there were people with leprosy who were heavily stigmatized because the disease was thought to be something highly contagious. Folks with leprosy were banished to live far and away from normal communities. It's taken decades to dispel this myth among the Hmong community. And even in certain places and communities, this misinformation, unfortunately, still prevails. That is why it is highly important that healthcare providers are able to dispel harmful myths and provide accurate information. Next slide, please. And then finally, we want to advocate for patients' rights by supporting patients in accessing healthcare services that they need, regardless of their immigration status. We want to try to provide resources and referrals to connect patients with organizations that can provide legal, social, and mental health support. Next slide, please. So for the next slide, I will talk about some best practices in utilizing medical interpreters to assist limited English proficient patients. As patients who come from a different cultural background, one of the biggest challenges is language. And according to the National Library of Medicine, patients who experience language barriers have been shown to receive poorer quality care than patients speaking the native language, contributing to well-documented health disparities experienced by migrant groups. Next slide, please. Currently, and since the COVID pandemic, many hospitals and clinics are using more and more remote interpreters, that is via video and telephone. However, these practices could still be utilized where applicable. Now, often out of habit, providers may want to look toward the interpreter. We want to try to avoid that instead and look at the patient when you're speaking to them. This can help encourage the patient to look toward and talk to you, the provider, as well. Now, professionally trained interpreters should and will talk in first person. For example, if the patient says, "I am not feeling well," the interpreter will say, "I am not feeling well," to the provider, instead of, "Oh, the patient said the patient's not feeling well." This is a small but important factor that can help keep the flow of the conversation to be as natural as possible. And I remember when in my training and reading on to become a medical interpreter, that one of the best ways or factors that we know that we're doing a good job as an interpreter is when we feel invisible and the connection between provider and patient is almost seamless. This is one of the few, medical interpreting is one of the few jobs where you are doing your job if you are feeling like you are invisible. So just something to think about. And then lastly, we want to take, as a provider, you should try to take pauses. Keep your message short and concise. The shorter and more concise it is, the easier it is for the interpreter to remember and convey what needs to be said. As sometimes it's hard enough to process one language to another, right? And add to that a bunch of medical information, and that is 2 times the challenge for the interpreter. So short and concise is easier for the interpreter to get the message across. Next slide, please. And then to conclude our presentation today, here are some key points to keep in mind. Keep in mind that many immigrant and refugee populations face a lot of health disparities, whether it is the language, culture, socioeconomic challenges, as mentioned, lack of health literacy, and simply having a different life experiences from war, trauma, and displacement will affect their outlook and understanding of receiving healthcare. You want to develop trust with your patient by using clear communication methods and applying cultural sensitivity to create a safe and welcoming environment. And then lastly, we want to be mindful of cultural humility. What this means is having the openness to learning and understanding other perspectives, while we are also acknowledging the limitations of our own knowledge and experience. It is a lifelong process of self-reflection that acknowledges our own biases and privileges, while actively working to address power imbalances in our interactions with people from different backgrounds. By implementing these strategies, healthcare providers can build stronger relationships with immigrant and refugee patients, improve their access to care, and ultimately enhance health outcomes. Next slide, please. So that brings our presentation to its end. And the final slide, next slide, please, is our email. If anyone would like to contact us, you can write to us. And for the last couple minutes that we have here, we'll be open to our Q&A session.
Wonderful. Thank you, Lisi. If anyone has any questions, please feel free to add them to the chat at the moment. This is our time. We also appreciate all the insights that you ladies have shared with us on building trust in culturally diverse clinic environments, and we're truly valuable for everyone working in healthcare. So we greatly appreciate your willingness to present today, and we're super excited to have you come. And if anybody has any questions, please put them in the chat at the moment. Also, we are always looking for, we do have a few questions. Here we go. We have one question that's, does anyone have any recommendations about how to ask about mental health history for Spanish-speaking patients? Yeah, Nina, I believe that would be yours.
Catherine,
Yes.
you were breaking up. Could you please repeat the question?
Yes.
To me, probably.
Okay. The question is, does anyone have any recommendations about how to ask about mental health history for Spanish-speaking patients?
Okay. Mental conditions is a sensitive topic, very sensitive. Actually, sometimes when people are diagnosed with mental condition, the family takes this they are scared about diagnosis. I want to say this. The best way to talk about this probably is the approach we have. Letting them know that is when someone is experiencing any condition, it is okay to ask for help. That is the best approach. Letting them know that it is okay to talk about their concerns. Latinos or Spanish speakers, they keep everything for themselves. It's like a shell. They put themselves in their shelves and they don't want to talk about their needs. So the only thing that I suggest is the approach. Education. Let them know that it is okay to feel sad. Let them know that it is okay to feel stress, because they don't recognize stress. Sometimes they say, I have a pain in my body. I have a pain in here, in my shoulders. But they don't know that is a consequence of stress. So let them know, education is one of them, the approach. Let them know that it is okay the way they are feeling. And it is okay. Even they say, okay, women can go to ask for help and men no because of machismo. No. Let them know that, okay, even in our communities exist machismo and marianismo. Both of them can go and visit a person who is a specialist in mental health. The approach, the way you talk to them, is going to be a key factor that is going to let them know that you care about the condition, about what's happening to them. And they are going to start trusting you.
Wonderful. Thank you, Yanina. We have another question. This is for the group. In addition to cultural awareness, how would you approach the topic of gender inclusivity in patient care?
I can answer that question if you let me. In my community, we have the Latinx term and the Latine term. If they identify themselves, I am a Latine, I am a Latinx, don't tell them, no, you are not, you are Latino. Okay, it is true that the translation of Latin America is America Latina, and we can be Latinos or Latina. Okay, according to the Real Academia Española, which is the Royal Academy of the Spanish language. But in order to be inclusive, we can use the terms they are using. So be respectful of the way they identify themselves. It is true that there are some rules when we write information, but when we are communicating ideas or messages orally, let's be inclusive and let's accept the individuals the way they are. If they want to be called Latine, yes, they are Latine or Latinx.
Wonderful. Thank you. One other question we have is what examples can be given for the provider to treat a patient when they have their belief of their own healers and herbal medicine?
Yeah, I can try to speak to that. Lisi here. Yeah, this is, in my own experience as a medical interpreter, have encountered with patients from the Hmong community, especially the older patients who have a strong belief in their own method of healing or types of medicine. I think as what I see providers have done is encourage them to, if they can, bring that in to share, like what kind of herbal roots or plants are you using, or tea? Like sometimes it might be some tea that's from a different country that they believe is helpful. And this is also useful, of course, to see if there are, if in case there might be any counteraction with the meds that the doctor might prescribe. Yeah, to let them speak about what types of healing or medicines that they're using. Ask them why they believe that what they're using is helpful. Encourage them that, explain to them that why, as a provider, why you recommend your method, as said in the slide. And yeah, I recognize that this can be a challenging topic for folks who strongly believe in their own ways of healing and treatment. As I said, related to I remember the elder Hmong patient who believed that it was black magic that affected his lungs. And the doctor, he simply listened, allowed the patient to speak of his experience and his belief, while at the same time he was explaining to him why medicine is needed as well to treat his latent TB. Yeah, I think just approach it with an open mind. Also show some curiosity into why they believe in their methods. That's what I would recommend.
Wonderful. And I think we have one last question because I know we're running short on time here. It is, what is the belief of preventative medicine in different cultures, for example, screening for cancers?
I can answer to that as well. Again, speaking for a lot of the Hmong patients that I've had experience in interpreting for, often there can be a pushback, especially patients who don't understand why preventative care is important. Often, and the reason for this is, in the culture, if you're not showing signs, like physical signs of pain, it's not showing up anywhere in my body, I feel fine. For example, hypertension, I feel fine. You don't feel it until something really serious happens, right? I think it's just a matter of emphasizing the possible consequences of not receiving preventative care and treatment. What could the possible results? Just education, educate the patient of why it is much easier to prevent than to try and cure an ailment. And yes, like I said, it's recognized that often if they're feeling well, then there might be resistance to getting the care or the preventative medicine that they need.
Wonderful. Thank you.
I would like to add just something. If you're working on preventative care, make strategic alliances with, for example, Hmong organizations, Somali organizations, Hispanic organizations. It is very easy for these organizations, I'm not going to mention the names, but they already have channel of information, direct information. And they trust when the information comes from these organizations, these partners.
Wonderful. That's a great idea, Annie. I really appreciate it. And I know we're just a couple minutes over time, but I appreciate everybody sticking around. And thank you again so much to Lisi, Yanina, and Dan Tam for your wonderful presentation. We will be following up next week with a follow-up email with your certificate of continuing education for those that are interested. We will also be posting our webinar to YouTube very soon. And we appreciate everyone for joining us today, and we look forward to seeing you on our next webinar. Thank you again, ladies.
Thank you.